Good morning, I'm Jessica Lovell. Today, we bring you an encore presentation of one of our very favorite programs. This one focuses on breast cancer. It is the most frequently diagnosed cancer for women, and we are learning more each day about risk and how genetics play a role. Today, you will meet two sisters. Right now, our team is working hard behind the scenes to bring you more amazing stories when our live programming returns in September. If there is an urgent update from the health system, we will be here to let you know first. Until then, please enjoy this encore presentation and make it a great day. Coming up, two sisters went to the doctor on the same day for the same concern, a lump in their breast. This morning, we talk about their diagnosis, their treatment, and they have a message for all women. Also, how they're navigating a path to survivorship together. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. When you hear that you have cancer, you often go in search for someone to lean on. Janine Kiesling introduces us to two sisters who didn't have to look too far.
Christine Leach and her sister Casey Hansen have always done everything together. As nurses, business partners, and moms with kids close in age, their days were filled with work, family, and morning walks with coffee chats. But nothing could have prepared them for the week they both discovered they had breast cancer.
We actually went to the doctor on the same day, but different doctors, and we didn't even tell each other. We didn't even know it.
For Christine, it was a triple negative breast cancer diagnosis. For Casey, it was invasive ductal carcinoma, and her cancer was hormone driven. The news was a blow that rattled their worlds.
This disrupted every part of my life and has changed me forever. I will never be the person I was before.
Christine's path forward was hard, but she found solace in the team at the University of Kansas Cancer Center.
I met Dr. Collins yesterday, actually, and she was amazing, was really nice and thorough, answered all my questions, spent a lot of time with me as well, and really explained everything and helped me through that process.
Meanwhile, Casey's journey took a more complicated turn. After her mastectomy, she developed an infection.
I was feeling feverish and chills. I had to go back in, and they took out both implants.
Casey had an infection that added an extra layer of difficulty to her recovery, but her care team at the Cancer Center got her through. Both sisters have always been proactive about their health, getting regular mammograms and doing self-breast exams, a habit that likely saved their lives. That, along with advocating for themselves and now inspiring other women to take time to do the same.
So just making sure you don't put yourself on the back burner, which most women do. It's okay if you have to miss work. It's okay, if somebody else has to pick the kids up from school, or just put yourself first for that day and make sure you get properly screened.
And we are so glad to be joined by both sisters today, Christine Leach, who goes by Teen, and Casey Hansen. And we're also joined by Dr. Kelly Rhodes Stark, a radiation oncologist and the Chief Medical Officer for the Kansas City Southwest Market of the University of Kansas Health System. Great to have you, Doctor, on the program today.
Thank you so much for asking me to join.
Yes, first time, right?
This first time, and this perfect platform for women's health.
Absolutely. First time and certainly not the last. We are glad to have Teen and Casey with us this morning. Just off the bat, ladies, how are you both feeling?
I feel good. I feel, my energy level and things like that are pretty much back to my baseline, and so I'm feeling well.
Teen?
I'm still struggling, but I'm getting there. But it's definitely a rocky road.
Well, can you share a little bit more about the day you both learned the news? I guess one of you got the call on April Fool's Day, is that right?
Well, I went in, I had a good friend of mine that was the breast navigator for Olathe. I had reached out to her when I found the lump on Easter night, and she made a big deal about it, that I need to get in the next day, and so I called and was able to get into my nurse practitioner at Dr. Snyder's office there, and she went ahead and put in orders, and she said I wouldn't be able to probably be seen that day, but my friend was able to get me in that day. So I went over and had diagnostic mammogram and an ultrasound that day on April Fool's Day, and they were able to tell from the imaging that it was a BI-RADS 5, which meant it was a pretty solid, I think a 95% chance that it's cancer. So I pretty much knew from that day that I had a problem. I just didn't know what exactly it was or how far it had gone.
Teen, what was that day like for you when you learned the news?
Well, for me, I really was in shock, first of all, with my sister's diagnosis. And knowing that we went to the doctor on the same day, we just didn't happen to mention it to each other. But when I got the call, I was at work. And my sister was calling me because she was on the way to a doctor's appointment. And she kept calling me saying, well, have you heard back yet? Have you heard back yet? And I really wasn't worried at all. So I hadn't even called to check. And so I did with her, to do so. And yes, and then they told me while I was at work that I did have breast cancer. At that time, I didn't know what type it was, triple negative, but my poor boss, he took the brunt of it when I found out, obviously upset. And it was very difficult to then tell my sister, who has already been diagnosed, that I also was diagnosed with breast.
Well, thank you for sharing that. Where do you both stand as of today regarding treatment? Any radiation or chemo left? Any immunotherapy?
So with mine, I did have surgery since they came out and interviewed us. I had surgery. I still had some residual cancer left in there. So it was small. It had shrunk by at least half. Nothing was in my lymph nodes, which is always good. But because there was something in there still, and it was triple negative, I do have to do more treatment. So as I thought I was done, and that has been a very deep struggle for me as I was preparing to go back to work and, to continue my life. I have found out I do have to have more chemo. I actually start tomorrow. And then I will be on immunotherapy most likely for 1 year after I complete this final chemo.
A question for both of you. Plastic surgery, breast reconstruction, where do you stand with that?
Well, I still have expanders in currently, so my surgery went better than Casey's, obviously, with her complications that she went through. But I am unable to do anything else until I complete my full treatment. So with that being the immunotherapy and chemo, I have to wait. So it'll be a long time before I'm able to complete my reconstruction.
Well, when we talk about, go ahead, Casey. Sure.
Oh, I had completed radiation with Dr. Rhodes Stark. She had, I think we did 16 treatments, so I've got that completed. And then with my having to go flat and then radiation on that side, it kind of limits what I can do for reconstruction, which, you still have options, just not all of the options. So you have to wait a period of time after radiation, about 6 months, before you can have reconstruction completed. But mine is probably using my own tissue. They call it a deep procedure. It uses your tummy, skin, and fat, and then they kind of build a more natural looking breast, the best you can get for, of course, it not being your own breast tissue. But so that is probably the option I'll go with at the time I'm able.
Ladies, when we talk about the status of cancer, we often use words like no evidence of disease or remission or I'm a survivor. But for each of you, how do you define or describe the cancer right now?
I think that's what's very tough because I don't know exactly what the doctors would tell us. They don't really say all those words to you exactly. But it makes you feel kind of uneasy about just what could be there or, what you're not seeing. There's not really any testing or lab work that we're doing to kind of monitor anything. And so you just kind of feel an in-between. And so I think that's just your life. And Dr. Rhodes Stark had kind of explained to me as the years pass, you'll feel more confident, things like that. But so it's just kind of an uneasy feeling, I think. And you're very hopeful, of course, that they've got everything, but you just don't know.
I want to bring in Dr. Rhodes Stark because that's you don't really think about it that way. We get excited about hearing survivor, or no cancer, or no evidence of disease, but it's not that simple. When you hear these words, how do you have those conversations with patients like Casey and Teen?
It is, it's complicated because there's all these definitions that we throw around. As providers and as physicians, we talk about no evidence of disease. So, technically, for both of these women right now, no evidence of disease. We'd say that they're in remission, even though we know that Teen has more therapy that's upcoming. There are some people that call survivors the day that they're diagnosed for as long as they live, survivors. Right. So there's all these definitions, and I understand, particularly early on, it is more challenging and uncomfortable for patients to say, hey, I'm disease-free.
But as far as you're concerned, this is good news so far.
Absolutely, for both of them.
And just to clarify, you're not the only oncologist treating these sisters. You handle the radiation portion of their treatment. Yes. But can you explain their different treatment paths? Teen needed the chemo first. Casey was able to do surgery first. No two people are the same, but you got two sisters. Why two different paths?
So I think this is really important. So if you're a patient and you have a diagnosis of breast cancer, I get this question all the time. Patient comes in and they say, you're recommending this. My neighbor had, this treatment and a friend had another treatment. And so why is that? So things that you want to know, education for yourself as you go into those appointments, is that treatment recommendations are based on a multitude of factors. Most important will be, number one, what's your age and your overall health? Number two, what is the stage of that cancer? Meaning, is it early or is it more advanced? And then finally, we talk about the biology of the cancer. So what does that mean? Well, it really will direct treatment recommendations. And so, for example, in Teen's situation, she had, as she alluded to, what was called triple-negative breast cancer. So what does that mean? When you have a breast cancer, it will be tested particularly for 3 different things. So your cancer cell, that we're going to look for what's called an estrogen receptor, a progesterone receptor, and HER2, or protein. And they can either be present or absent in any combination. But when they're all 3 absent, that is what's called triple negative, because all 3 are absent. What we do know is that those are more aggressive cancers. They're typically found in younger women, dense breasts, as well as increased incidence in Black women. And so with triple negative, because we know they're more aggressive, we have to be more aggressive. So those patients will typically get chemotherapy and or immunotherapy based on the stage first, and then surgery. And so that's what Teen had. In Casey's situation, even though they're sisters, different type of breast cancer. So hers was estrogen receptor positive, progesterone receptor positive, HER2 negative. So based on a multitude of factors, her treatment path was surgery first, reevaluate, see if there's any role for chemotherapy and or radiation. And in her situation, radiation was appropriate, and her sister's was not. So I think it's really important, has to be tailored to that person.
Great explanation. So different types of breast cancer, but is there a hereditary factor here? And when does genetic testing come in?
So there can be. The interesting thing for these ladies is that if I was betting, I would have thought that we would have found a genetic mutation for them because they are so young. But genetic testing is so important for a certain subset of patients. So if you're less than 50, triple negative, metastatic disease to start with, male breast cancer, Ashkenazi Jewish heritage. There are other things. If you have a close relative who had breast cancer at age less than 50, and we can go on and on and on. But those screenings are done. So if you're coming to the University of Kansas health system, you have that biopsy, the breast nurse navigator does that screening initially and says, oh, you may benefit from genetic testing, let's get that done. And that's very important.
Such an unusual case though. I have an older sister. I can't imagine hearing that she had breast cancer and then you're having to deal with it yourself. Yes. And just kind of where do you turn? the benefits and the negatives of it. Just what do you make of a case like this?
So I have to say, this is one of the reasons when they asked me for Breast Cancer Awareness Month, is there a story that you'd like to share, that I initially, of course, thought about Teen and Casey. Because this is so unusual to have different types of breast cancer diagnosed at the same time. This is not typical. But what we do know is 1 in 8 women will have a diagnosis of breast cancer, right? 85% of those patients do not have a family history. So what, if anything, if people take away from this, it's, get screened, know your history, and be proactive for your health care.
Teen, you told us that losing your hair was hard. We've heard patients say that before. From your perspective, what made the hair loss particularly a challenge for you?
Really, that's just a public viewing that everyone strips you of all your dignity, basically. That either you're bald or you have a wig on, or something like that. And for me, that was definitely, and I know for most women, it was very, very hard. Very hard. I had a 9-year-old at the time of my diagnosis, and she actually cut my hair for me, so she was helpful. She's 10 now, and she is very much still affected by the fact that mommy doesn't look like mommy.
We're going to have a show coming up here, I think next week, just talking to your kids about breast cancer and cancer in general and what it's like, and those conversations, the tough conversations that you have to have. Casey, your surgery gave you a different challenge. I understand that after the double mastectomy, that one side wasn't healing well. Tell us a little bit more about what happened there.
I was 6 weeks out, and so I had a little spot on the right side, which is where the cancer was, that wasn't healing. And so actually, I ended up going back in. I was trying to get radiation started. So Dr. Rhodes Stark had glanced at that spot just to see, did it heal or did it not? And it hadn't. So I was on my way to go see Dr. Korntager anyways, or his nurse. And so then when I got there, that you could actually see the implant like through there. So they said that had to be explanted, and everything cleaned out, and then a new implant placed. So we did that, I think, on a Tuesday. And then it was Thursday or Friday, I can't remember. I knew I didn't feel good, and I can usually push through about anything on like surgeries and things. I don't miss a day of walking, or I like to be up and moving even if I don't feel that great, but I did not feel good. And I felt feverish chills, and so I ended up having to be admitted to start IV antibiotics, and they were able to get me into surgery that same day. And so they had to take me flat. My option was, the right only or bilateral, both sides, So I just went ahead with both because it was, things were going to look different from then on out anyways. And I knew I was going to do radiation. So, but then I had that PICC last, I ended up with a blood clot. So it was kind of that was probably the roughest part for me.
How common are complications with implants?
Well, first of all, I'm not a plastic surgeon, but what I would say is that, any type of procedure, we can always have complications, right, side effects, but something like this is very uncommon. Most of the time, if there are complications, there are things that are cared for in an outpatient setting and taken care of. So this was unusual.
Casey and Teen, I know you mentioned that you've been leaning on each other, as we know, but you have a big support system. Who's been in your corner? What does that support feel like and look like?
Well, I mean, we're both married and have kids, and then our parents that are supportive. So for me, my dad he insists on like driving me to any and all appointments instead of me driving myself. So he takes me to about everything. And, our kids are supportive as they can be, and, our spouses.
Yeah, my husband takes me to every treatment. And I have especially like work family that has really been very helpful. They bring me meals and just support me in all sorts of ways and let me vent to them. And I try not to vent to Casey too much because I know she is going through her own. So I sometimes take it out on some of the work people, and they allow that, so that's fine. And I also get driven by Dad to some appointments. We enjoy being in the hammer lane, going slower than the speed limit.
Yeah, it's really rough.
So if you see us, just give us a wave, particularly with all 5
Yeah, it takes a family. It takes your family, your work family, and everyone around you. I have some questions about screening and dense breasts coming up. But if you have any questions, use the chat on YouTube or Facebook. You can email the Medical News Network. That information is on your screen. Let's talk about mammograms. I got mine last week. You'll be glad to know.
Good for you.
And a shout out to my boss. And because Teen, you had mentioned that you kind of had a lead on your boss and your work family. My boss said I had a appointment out of Olathe. I found they could get me in right away. She's like, go. Mammograms come
Isn't that
first.
great?
Mammograms come before work. So if you're a boss, let people leave work so they can go get their mammograms. So just so important. Generally speaking, though, women should start at age 40.
Yes.
We've heard that, or earlier if they're at a higher risk. I want to talk to the ladies because, Casey, you were diagnosed at 42. Teen, you were at 39. Why were you getting mammograms before 40?
I actually even had a biopsy done when I was like 19 because I had a little lump. So my breasts are just kind of cysty and things like that. So I was actually getting mammograms or ultrasounds every 6 months, with my last mammogram and ultrasound being February of 2023. And at that time, they said nothing has changed in 2 years. So I was fine to not continue them until age 40.
And I understand both of you have dense breast tissue. When and how did you learn that?
Well, I know that they had told me that when they were doing ultrasounds and things, and in my mind, I didn't even think twice about it. I just figured, okay, yeah, I got dense tissue, and I figured, if there's something else I needed to do or things like that, that they would guide me in that direction. I didn't realize that the dense tissue really can cause a lot of trouble when detecting cancer and things like that. Dr. Roadstark had actually showed me some things about the white tissue in there, and it looks very similar to cancer. So for me, I knew they had told me that, but I didn't know the dangers that could cause.
Well, let's take a look at it. Oh, go ahead. Yeah, please.
I was aware that you had trouble seeing through dense breast tissue, but I assumed that if they were not able to see anything, they would tell me, hey, you need to do something different. So every time I got my results saying, hey, everything looked good, you have dense breast tissue, I just took it. We don't have any family history or anything. I just thought, okay, yeah, I'm good. But I had a mammogram in October or November, I think November of the previous year, and my cancer had been there for a while. So it was definitely there then, and probably every mammogram I've had, I don't know, but it just wasn't seen.
Dr. Roadstark, I mean, that's it. It's tough to spot, and you can tell by looking at this animation. Kind of walk us through what we're seeing here from left to right.
Sure. So these are the 4 types of densities that we can see on mammogram. So as you can see, the first one, it's pretty easy to see that little lump right there, that white lump, right? Mm-hmm. Yep, there we go. We got those red circles there. And that's because the breast is mostly fat replaced. So as we age, we lose those milk ducts, more fat replaced. It's easy to see through these breasts. Okay, then you go to the next, which can have some density in there, and you can still see that nodule pretty easily. Then you go to the next, which could be heterogeneously dense, becomes a little more challenging, and by the time you get to that extremely dense tissue, it's like a needle in a haystack, is what you're seeing there.
And so if somebody doesn't know that they have dense breast tissue, what should they do? And once they discover they have it, what's the further screening they need?
So I want to key in on what our guest said here. It's like, oh, you get the report, well, see you in a year, everything looks good. And then there's this note about the density. So this is interesting. 2023 is when the FDA mandated that on your mammogram report, it has to state the density, okay? Before that, not necessarily there, all right? Now, here's the next step, is that, as it was also alluded to, well, if this needs to be further looked into, somebody's going to tell me, right? I don't expect my patients to self-diagnose. So there is now, right now, something called the Find It Early Act. Find It Early Act. So this is something that was actually introduced by Katie Couric and then taken up by some other senators and congresspersons. It's a bipartisan act. And what it's saying is that when women have this report that says you have dense breasts and you could benefit potentially from extra screening, which could be ultrasounds of the breast, could also be MRI of the breast, and a screening MRI of the breast is really actually pretty easy. It's not a 45-minute detailed exam when you have a breast cancer, but we know that 45% of women that are having mammograms have these dense breasts. So if you have dense breast and then it says, okay, you could benefit from extra screening, that really shouldn't be on the patient. And so what should happen is that your physician or you should be able to go to that next screening. Right now, not all insurances cover that. And so what we're doing is we're placing barriers to care for women, particularly those in lower socioeconomic areas where they may have to make a determination, am I going to pay hundreds of dollars for ultrasound or a fast screen MRI? And I don't really have that. And that's not right. And so again, if you can look online, the Find It Early Act, there's links, just contact your congressperson, your senator, say, hey, this is bipartisan, we need this enacted. This is a health care benefit and it's very important for women.
Find It Early Act.
Find It Early Act.
Thank you for bringing that up. Really, really important. I want to get to some questions from our audience today. Yan Liang, many women are concerned about the pain during mammography. Is the 3D mammogram less painful compared to traditional methods?
Not necessarily.
Okay.
So 3D, I always talk about, and really at KU, every mammogram is going to be 3D, both 2D and 3D. So the way I explain it to patients is that a 2D would be like taking a book, right? And you're going to look at the cover and you can turn it this way and this way, and that's about it. A 3D is basically you're leafing through each page. So it's like every millimeter you're getting an image. So you don't really realize that that image is being done, but there's no difference in the pressure.
Okay, so you're still doing what we think of as a typical mammogram.
Yep.
Okay, just sometimes you got to do what you got to do.
Yep.
Marcia says, can you talk about how radiation affects breast tissue and what post-treatment patients can expect over time?
Oh, that's very important. And this is near and dear to my heart because one thing I'll tell you is that the advancements in radiation therapy are dramatic for breast cancer. So years ago, we used to treat the whole breast very typically following a lumpectomy, and a patient would come in usually for about 6 weeks of radiation, once a day, Monday through Friday. And this was the dose that was shown in trials to get rid of potential microscopic cancer cells. The same was pretty typical for following a mastectomy for women that had high risk of recurrence, local or what we call regional in the lymph nodes. Those women would typically come for 5 weeks of treatment. Fast forward, trials, technology, and we've reduced that now so that in many women we can treat just the lumpectomy cavity if their breast is intact. I have a lot of patients that I do 5 treatments. So I used to do 30 treatments, 6 weeks of treatments to the whole breast, and now I can do 5 to just that area. What that does is it reduces dose to normal breast tissue, better cosmetic outcome, same overall cure rate. And then also, Casey alluded to the fact that she had 16 treatments. It used to be 25. We've now gone to 16 treatments. So that means less scar tissue, less tightness, less long-term side effects.
Jeremy says, I didn't realize triple negative was more common in younger women. Why is that?
We're not exactly sure, but we do know it is more common in younger women and as well as with dense breasts.
Teen, Casey, thank you so much for sharing your story with us today. Teen, I'll start with you. What do you want people to take away from it?
Really, I think both of us would agree. We just would like for women to really make sure that they are checking, they're going to their mammograms, and that they're, pushing for that ultrasound or that MRI if they have to push for it. If it says you have dense tissue, don't just walk away. Go push for more testing.
Casey, what's the big takeaway?
Yeah, that's it's kind of my soapbox now. I don't want to say I harass people, but I do a little bit. My work gals and everything, I'm messaging them like, have you had your mammogram? Like, I just want to make sure everybody gets their mammogram, but not only gets that, if they have dense breast tissue, I want to make sure they take it to the next step, because mine could have been caught a long time ago had I done that. And so I just, I don't want anybody to be, in a situation where they're, not able to treat, maybe they're farther along, advanced in their cancer staging and that kind of thing. I want them to be caught early and to kind of have control over how their life goes from that point. You don't have any control over your cancer journey, but, we hope to live long lives and see our grandkids and still be productive members of society and enjoy life. So we want everybody to be able to do that.
Thank you again for sharing. And mammogram harassment, I think we're okay with that, aren't we?
I think that's an acceptable harassment.
Very acceptable. That is it. It stops with that, but very important and great message. What's the big takeaway?
Find it early act. So check your mammogram report. If you have dense breast, reach out to your provider, say, hey, I'd like some supplemental screening. And we need to hold insurance companies to the fire and say, this is just a standard of care, right? We need to find breast cancers early, and this should be covered by insurance, just like your annual mammogram for appropriate patients.
Thank you for driving that home today.
Okay.
Thanks, Doc.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now everywhere podcasts are available.